Hello and welcome to part 2 of our trigeminal nerve journey. I am Tanya Chamberlain from the Division of Anatomy here at the University of Leeds, and in this video we are going to look at the mandibular branch of the trigeminal nerve. Let's have a recap of the trigeminal nerve that we have covered so far. The trigeminal nerve, also known as cranial nerve 5, is one of the 10 cranial nerves that emerge from the brainstem. We have 12 cranial nerves in total. The trigeminal nerve, like a lot of other cranial nerves, carries a mixture of fibres, having a large sensory root and a smaller motor root. Both roots exit the brainstem in a region known as the pons. The sensory root forms a ganglion of sensory cell bodies almost immediately after exiting the pons. This is known as the trigeminal ganglion. Let's have a reminder of that ganglion. The trigeminal ganglion is formed from the sensory cell bodies. It contains no motor fibres or motor cell bodies. There are no synapses between neurons in the trigeminal ganglion. Instead, the motor root travels alongside the sensory root and blends in with the sensory fibres after the third branch of the trigeminal nerve exits the skull. The sensory ganglion does exactly what it says on the tin. It conveys sensory information. This is through a variety of modalities, so we can see the sensations of pain, temperature, touch, proprioception and pressure are transmitted through this ganglion from the skin of the face, the muscles, the TMJ, the mucosa and the teeth. Please note that although I have just stated muscle, the sensory ganglion does not innervate muscular action. This would be a motor nerve, but instead it acts to feel what that muscle is doing. This is particularly important for proprioception and reflex arcs, which prevent us from using the muscle when damaged. We also looked in part 1 at how the trigeminal nerve gets from the cranium to the face, the nasal and the oral cavities. The first division, the ophthalmic nerve, exits through a fissure at the back of the orbit called the superior orbital fissure. This is easier to see on this image. This is a zoomed in picture of the right orbit, commonly known as an eye socket. We can see two large black slits at the back of the eye socket called fissures. The one we are wanting to identify is this one, the superior orbital fissure. The second branch of the maxillary nerve exits through a small hole in the base of the skull, called the foramen rotundum. When looking at the cranial base, this one is identifiable by its shape. Rotundum means round, so this foramen or hole is incredibly round. Lastly, we have the mandibular branch. The mandibular nerve exits through a hole called the foramen ovale. Like with most things in anatomy, we say what we see, an oval hole and thus a foramen ovale. Now we have recapped some of the things we looked at in part 1, let's break down the learning objectives for this video. By the end of this video and after any further study, you should be able to describe in detail the course and the branches of the mandibular nerve. Identify the main features of the mandibular nerve in diagrams and in cadavers. And describe examples of dental anaesthetics that can be applied to branches of the mandibular nerve. So let's move forward and look at the course and the features of the trigeminal nerve. This picture shows V3 from the medial aspect. The head has been sawed in half down the midline and we are looking at the right side of the head from the inside. The muscle with the bite taken out of it is the medial pterygoid. Well done if you managed to work this out. At last we can see the motor root of the trigeminal nerve clearly. You'll remember that it was covered up by sensory components of the trigeminal nerve in most of the slides that we have seen so far. Immediately after they emerge into the infratemporal fossa, the motor root merges with the mandibular nerve. This means that V3 is the only division of the trigeminal nerve to contain motor fibres as well as sensory fibres. Immediately after the motor root has joined, V3 sends motor branches to several muscles. The only one of these branches you need to know about is imaginatively named the nerve to the medial pterygoid. Just after these branches leave, V3 divides into a small anterior trunk and a large posterior trunk. However, before we get onto those, let's just mention the round structure that you can see in this picture. If you've worked it out already, I'm impressed. Remember salivation, specifically the secretomotor pathway to the parotid gland? Yes, this is the otic ganglion, where the preganglionic parasympathetic fibres of the glossopharyngeal synapse with their postganglionic counterparts. You may remember the latter reach the parotid gland by travelling along with the branch of V3, called the Auriculotemporal Nerve. We'll return to this nerve in a few moments. We return here to a more familiar view of the mandibular nerve, that is, seen from a lateral aspect. This picture shows two trunks of V3 very clearly. These are the anterior trunk, which is almost entirely motor, but it does have one sensory branch, and a posterior trunk that is almost entirely sensory, but has one motor branch. In this picture, we can see several branches that arise from this little trunk. There are two nerves going to the temporalis muscle. These are called the deep temporal nerves. The masseter has been removed in this picture, so all that's left of the nerve supplying it is this little stump from the anterior trunk. Then there is a branch going to the lateral pterygoid muscle. This is called the nerve to the lateral pterygoid. In an intact head, this nerve continues to pass through the mandibular notch before entering the deep surface of the muscle. So that's three of the muscles of mastication that are supplied by branches that come off the anterior trunk. That leaves just one more branch of the anterior trunk to consider, the long one that runs into the cheek. This is called the long buccal nerve. While all the other branches of the anterior trunk are purely motor, the long buccal nerve is purely sensory. It supplies the skin over the cheek and the corresponding buccal mucosa on its deep surface. Don't confuse the buccal branches of the facial nerve with these long buccal branches. The buccal branches of the facial nerve are motor nerves supplying some of the muscles of facial expression, including the buccinator. The long buccal nerve provides the skin sensation and the mucosal sensation via the trigeminal. The posterior trunk has three branches: the auriculotemporal nerve, the lingual nerve, and the inferior alveolar nerve. All the trigeminal fibres in the auriculotemporal and lingual nerves are sensory. The inferior alveolar nerve contains both sensory and motor fibres for part of its course. The first branch of the posterior trunk is the auriculotemporal nerve. As mentioned earlier, we've come across this nerve before when we looked at the secretomotor supply to the parotid gland. Please be very clear though, the trigeminal fibres that run in the auriculotemporal nerve have nothing to do with secretion. They are all sensory fibres. The auriculotemporal nerve is shown very clearly in this picture. It has a rather odd and very characteristic relationship with an artery just after its branch from the posterior root of V3, in that it splits to go around the vessel. The vessel itself is the middle meningeal artery. It's quite interesting because this has considerable significance in terms of clinical complications. It enters the cranial cavity and runs along the inside of a particularly fragile part of the skull. A blow to the side of the head can rupture this artery, resulting in a so-called extradural hemorrhage. This can be fatal. So what do the trigeminal sensory fibres running in the auriculotemporal nerve supply? Well, you can see that it leaves the infratemporal fossa and runs up the side of the head. There, it provides the sensory supply to the skin on parts of the auricle. That's the fleshy thing known as the external ear. And on the side of the head, known as the temporal region. This is how the nerve gets its name. For dentistry, probably its most important function is to provide sensory supply to the temporomandibular joint. The TMJ is subject to all sorts of problems and cause the patient significant pain. The pain fibres supplying the joint are trigeminal fibres that run in the auriculotemporal nerve for the first part of their journey back to the brain. This image gives you a more comprehensive view of the journey of the auriculotemporal nerve. Here I have highlighted a couple of the regions that we have looked at. Here is the temporal region and the auricle of the ear. And this is the TMJ. We can also see the superficial temporal artery and the maxillary artery and the auriculotemporal nerve emerging just after the maxillary artery and travelling superiorly with the temporal artery. On this image, I have returned the parotid gland to its home behind the ramus of the mandible, and we can see the auriculotemporal emerging just behind the parotid gland. In this picture, we can clearly see the sensory branch of the mandibular nerve running through the infratemporal fossa just superficial to the medial pterygoid muscle and then onwards to the tongue and other soft tissues nearby. One of the features of the lingual nerve is that it supplies the lingual gingiva of the mandibular teeth. It does not provide any supply to the teeth themselves. You should remember from Introduction to the Oral Environment that the lingual nerve also provides sensory innervation to the anterior 2/3 of the tongue, and that it carries the facial nerve sensory fibres that service taste in the same area. It also transmits secretomotor fibres that pass to the submandibular and sublingual glands. You'll remember that these facial nerve fibres get to the lingual nerve when it is joined by the chorda tympani. Another important feature of the lingual nerve is that it runs through the infratemporal fossa just a few millimetres anterior to the branch of the mandibular nerve we're going to consider next, the inferior alveolar nerve. Because the lingual nerve lies so close to the inferior alveolar nerve at this point, applying local anaesthetic in this region blocks both nerves at the same time. And on this image we can see the lingual nerve with the cadaveric donor. If you are wondering where you can find images like this, grab a digital copy of Gosling's Human Anatomy from the library, and you'll be able to see a sketched image at the side of a cadaveric image to help you identify the structures within each picture. The textbook itself is in a little too much detail for dentistry practice, so be cautious when using this book for revision, but the pictures and the descriptions of the images are very good. Now this picture isn't entirely useful for the inferior alveolar nerve, as a whole stretch of the nerve is missing. The missing section lies inside parts of the mandible that have been removed, so we can see more deeply into the face. That said, we can see that the inferior alveolar nerve emerges from V3 at the same time as the lingual nerve. Effectively, V3 splits in two to produce two nerves. The inferior alveolar nerve runs downwards through the infratemporal fossa, just behind or posterior to the lingual nerve. Just like the lingual nerve, it is lying immediately superficial to the medial pterygoid at this point. Just before it enters the mandible, the inferior alveolar nerve gives off the one and only motor branch of the posterior trunk of V3, the nerve to the mylohyoid. There are no prizes for working out that this supplies the mylohyoid muscle in the floor of the mouth. What is far less obvious is that it also supplies the anterior belly of the digastric muscle. The posterior belly is supplied by the facial nerve. Before we carry on and look at the inferior alveolar nerve, let's just divert for a moment to make sure that you know about the mylohyoid muscles as these definitely have relevance to clinical dentistry. The first picture shows the left and the right mylohyoid muscles. They arise from the mandible and run downwards and medially to fuse at the midline, though you can't see where they join as there is another muscle in the way in this diagram. The two fused mylohyoid muscles form a sheet of muscle in the floor of the mouth. You can see, as their name suggests, they also join to the hyoid bone. The mylohyoids have an important role in the early stages of swallowing, when they move your tongue upwards and towards the hard palate in order to push the bolus of food backwards towards the pharynx. The mylohyoids arise from very prominent ridges of bone that lie deep to the surface of the mandible body, one on each side. These are called the mylohyoid lines. They are important in the field of dental prosthetics, so you need to know where they are and why they are there, and that's to attach the mylohyoid muscles. The nerve to the mylohyoid comes off the inferior alveolar nerve and initially runs in the groove that lies just below the mandibular foramen. This is called the mylohyoid groove. It is visible on the left picture on this slide. This picture shows the left mylohyoid nerve running within the left mylohyoid groove. It also shows very clearly that the inferior alveolar nerve enters the mandible through the mandibular foramen, just after the nerve to the mylohyoid branches from it. Once inside the mandible, the inferior alveolar nerve runs anteriorly through the mandibular canal, where it can also be called the infraalveolar canal. As it does so, it gives off a tiny unnamed branches which supply the mandibular molars and the second mandibular premolar. In the region of the second premolar, the inferior alveolar nerve splits into its terminal branches, the incisive nerve and the mental nerve. The incisive nerve continues inside the mandible to supply the first mandibular premolar, the mandibular canine, and the mandibular incisors. Though note that the central incisor can receive innervation from the contralateral incisive nerve as well. The mental nerve leaves the mandible through the mental foramen. You'll remember we first met the mental foramen way back in our first lecture of anatomy for the introduction to the oral environment. The mental nerve supplies the skin and the mucosa covering the lower lip and the labial or buccal gingiva of the incisors, canine and premolars. That leaves the buccal gingiva of the molars to consider. These are supplied by the long buccal nerve, that sensory branch of the anterior trunk of V3 that we came across earlier. Important to know that this means that the gingiva are not anaesthetised by an inferior alveolar nerve block. So now we have looked at the course and the innervations of the mandibular branch of the trigeminal nerve, let's go and have a look at some of the blocks that can be applied to these nerves. The inferior alveolar nerve block is one of the most frequently used in dental anaesthetic procedures. It is also called the inferior dental or ID block because the inferior alveolar nerve is often incorrectly called the inferior dental or ID nerve. It aims to anaesthetise the inferior alveolar nerve in the temporal fossa just before it enters the mandibular foramen. In the case of the maxilla, we saw how these nerves supplying the teeth were different to those supplying the gingiva on their medial or palatine aspect. In the case of the nerve blocks, different procedures were required to anaesthetise these two sets of nerves. In the mandible, when supplying the teeth, the inferior alveolar nerve, including its terminal parts, the incisive nerve, is also distinct in that it supplies the gingiva on the medial or lingual aspects of the teeth. However, just a single nerve block is used to anaesthetise both of these sensory supplies simultaneously. This is because the inferior alveolar and the lingual nerves lie close to each other at the site of the anaesthetic solution that is injected, just before the inferior alveolar nerve enters the mandible. So an inferior alveolar nerve should anaesthetise or the ipsilateral mandibular teeth, the lingual gingiva of these teeth, and the buccal and labial gingiva of the premolars, canine, and incisors. Remember that the central incisor can receive innervation from both sides of the head, so it may remain sensitive even when an ipsilateral inferior alveolar block has been applied. The buccal gingiva of the molars is supplied by the long buccal nerve, which is not affected by an inferior alveolar nerve block. A buccal nerve block will anaesthetise this gingiva. This procedure aims to block the buccal nerve as it crosses anteriorly to the ramus of the mandible on its journey to supply the cheek and associated structures. It should be clear by now that the buccal nerve block alone does not anaesthetise any teeth. As we mentioned before, the inferior alveolar nerve branches in the region of the premolars. One branch comes from our mental foramen as the mental nerve, whilst the other continues inside the mandible as the incisive nerve. The mental nerve can be blocked as it emerges from the mental foramen. This is usually located between the apices of the two lower premolars. The mental block anaesthetises the lower lip and the labial buccal gingiva of the incisors, canine, and premolars. If you want to block the anterior teeth at the same time without resorting to an AI block, you can modify the mental block to produce an incisive nerve block. The incisive nerve block is very similar to a mental block, but it uses a greater volume of anaesthetic fluid and the pressure applied to the region in the mental foramen as the solution is injected. This forces the solution into the mandibular canal, blocking the incisive nerve. Of course, it also blocks the mental nerve, as this is also bathed in anaesthetic solution as it emerges through the mental foramen. The incisive block anaesthetises the same structures as the mental block, as well as the teeth supplied by the incisive nerve. And this brings us to the end of our trigeminal nerve. I hope you have enjoyed this journey as much as I have enjoyed teaching you. You should now be able to describe in detail the course and the branches of the mandibular nerve. Identify the main features of the mandibular nerve in diagrams and in cadavers. And describe examples of dental anaesthetics that can be applied to branches of the mandibular nerve.